Let's move on and take a look at a few cases that are relevant to our discussion. So this is the first case. This is a 45-year-old male with chronic sinusitis and conductive hearing loss. What do we see? We see a mass lesion. Let's take a look. This is a contrast-enhanced axial CT scan at the level of the nasopharynx. This is an axial T1 contrast-enhanced MRI. And this is a bone window of that enhanced axial scan. So what we see on the soft tissue window of this axial scan is that there is a soft tissue mass that is centered in the right nasopharynx. A very similar finding is seen on the MRI, and you notice that it is centered in the fossa Rosenmuller. Another thing that you notice is that there is effusion or opacification of the right mastoid air cells. This patient had conductive hearing loss, which is likely from this effusion, and the effusion is caused by an obstructive lesion in nasopharynx that is occluding the eustachian tube and results in the eustachian tube dysfunction. So what could this be? This turned out to be a nasopharyngeal carcinoma. And as we remember, nasopharyngeal carcinoma is located in the pharyngeal mucosal space. This is a classic case of this etiology. As you remember, nasopharynx as part of the pharyngeal mucosal space is in direct contact with the skull base. You also remember there are multiple okay, so we're going to stop it here, and then we're going to move on to the coronal. Next slide. All right, so next slide now. This coronal T1 post-contrast image of the brain demonstrates intracranial extension of the lesion, of this nasopharyngeal lesion, with widening of the right foramen ovale, indicating that it probably is due to perineural spread of tumor along the alveolar branch of the trigeminal nerve. However, direct extension is also considered. On the left side, you can see actually a normal, non-widened foramen ovale. So this is an example of intracranial extension via foramen ovale. Next case. A 27-year-old woman with incidental left parotid mass. This is a T1 weighted axial MRI of the neck on the left, and on the right you see a T2 weighted image. And what is seen here is a well-defined T2 hypointense and T2 hyperintense lesion that is most likely located or originating from the parotid space. How do we know? We know it because if we look carefully at the parapharyngeal space, it is displaced anteriorly. And remember, things that displace the parapharyngeal space anteriorly most likely come from the parotid space. Another sign that this lesion originates from the parotid, deep space of the parotid, is that it traverses and widens the gap, the stylomandibular gap. This turned out to be a pleomorphic adenoma that originated from the parotid space. So remember, all those signs and the displacement of the parapharyngeal space is very important, especially at the level of the nasopharynx and oropharynx. These are different examples of the parotid space lesions, and here we can see on the left side, within the left parotid gland, there is a pleomorphic adenoma that is seen as a hyperdense lesion. This is an example of adenoid cystic carcinoma, and what's important to mention is that the adenoid cystic carcinoma is the most common lesion of the parotid that tends to spread via perineural extension. So perineural extension is very common in adenoid-cystic carcinoma. Next slide demonstrates a capillary hemangioma, which is a vascular malformation within the parotid gland. And finally, this slide demonstrates a lymphoepithelial cyst within the parotid space in a patient who was HIV positive. This is a 4-year-old child who presented with facial fullness. And what we see here on these axial contrast-enhanced CT scans, on the right, that there is a mass lesion that is centered within the masticator space, and it appears to extend or extends intracranially. On T1 post-contrast MRI of the neck, this lesion is heterogeneously enhancing and possibly necrotic, and it does extend intracranially. Because we know that this is centered in the masticator space, the most common lesion, especially in the child, would be rhabdomyosarcoma, and it was proven to be this pathology via biopsy. Another space, another lesion. Here on this axial contrast enhanced CT, we have the axial CT and the axial a little bit lower down, followed by the coronal plane, through a lesion also within the masticator space, both medially and lateral to the ramus of the mandible. What you can see is that there is this hypoenhancing lesion with areas of gas that is centered in the masticator space, with surrounding soft tissue swelling and fat stranding, but also it extends into the infratemporal fossa. But what's important to note is that on the bone window, you can notice that there is a periapical lucency within the mandibular molars that most likely consistent with a periodontal or periapical abscess and odontogenic disease with adjacent soft tissue abscess formation and cellulitis. So this is an example of odontogenic abscess in the masticator space and infratemporal fossa. And this case is that of an older patient who presented with swelling of the right face. And what we can see here is this hyperdense calcific density in the buccal space, And there is almost a tubular structure and or fluid collection within just superior to the masticator space and also involving the masticator space, with significant surrounding soft tissue swelling and skin thickening and subcutaneous fat stranding. All these inflammatory changes, as well as the calcific density in the buccal space, is the parotid duct stone. So this is the lithiasis of the parotid duct that causes sialadenitis within the buccal space. Moving on a little bit inferiorly, we are in the visceral space now. What do we see here? This is the thyroid gland, enhancing hyperdense structure that is the thyroid gland, and we can see a fairly large lesion within the isthmus and the left lobe of the thyroid, with punctate calcifications that were also seen on the ultrasound. This turned out to be papillary carcinoma of the visceral space. This patient presented with inability to swallow and hoarse and potato-like voice. When we scanned this patient, this is what we saw. Where are we is the first question, and what is it is the next question. Where are we? We are is that we, ooh, sorry. Okay. This is our next case. This is a patient who presented with hoarseness and inability to swallow, dysphagia, dynaphagia, and hot potato-like voice. What we see here is a rim-enhancing collection in the retropharyngeal space. There's mass effect on the airway. There's surrounding swelling. This turned out to be a retropharyngeal abscess. Going into the carotid space, we see a lesion at the bifurcation of the common carotid artery, where it bifurcates into the ECA and the ICA. There is an enhancing lesion right there at the bifurcation on the sagittal CT. On the axial, again, we see a highly vascular, hyper-enhancing lesion at the level of the carotid bifurcation, and the angiogram demonstrates a vascular lesion that splays the ECA and ICA, and that is being treated with endovascular coiling quite effectively. So what is it and where is it? It's obviously in the carotid space, and at the level of the bifurcation, we know that this is a carotid body tumor. It is possible and is advisable to embolize this lesion preoperatively to decrease intraoperative bleeding.